Hello, hello.
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 We will uh we will get going here just shortly. Appreciate your patience. I've got a 5 to 6 p.m. class that some of y'all were on. I think Art or Shula, right? You were there.
Yes, I was there.
Awesome. And Owen, you're not in my child and adolescent class, are you?
No, but my name's
Okay.
Stacy. That's my husband's name.
Oh, okay. Sorry, Stacy.
That's okay.
We will give folks just a couple more minutes to get going, coming in, and then we'll be jumping right in.
Dr. Armstrong, you couldn't hear. I changed computers because you couldn't hear me last other computer. But
oh, okay. Yeah, I can hear you now. Yep.
I wanted to be sure I'm understanding in terms of the quizzes. Like the first one, I can't remember. One of the classes was 1 question, the other one was 5. So
right.
I think going forward, I'm expecting them to be more like your other test where there's a lot more questions. Or are they short quizzes always?
Yeah, they're all 5 questions,
okay.
Except for one of them.
That, and I know you've shared that information. I've forgotten that. Okay.
Mm-hmm. Yeah, they're all just 5 questions.
Okay.
And they're basically like my test questions normally.
Okay.
Yeah, probably even a little bit easier than my test questions. Well, I don't know. I don't know how to gauge whether they're easy or not, but I guess I write them that I wrote them in a way to follow the DSM-5 a little bit closer than my typical test questions. Yeah. And when I told the previous class, I had a student talk me into it, and I think it's fair and only reasonable to offer it to this class. Is to make sure that you all know that you will have 2 attempts for each quiz from here on out. And so if you didn't score as high as you wish you would have on a quiz, you will have one more shot at it. That'd be helpful for you guys. If anybody doesn't want an extra attempt, just let me know. I'll be glad not to give you an extra attempt.
Oh, no, I appreciate it very much.
Thank you.
I had feedback one time from a student that said, great teacher, blah, 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 but I wish we wouldn't have had 2 attempts for our tests. And I kept thinking, like, so you wish you just had 1 shot at it, I guess. Okay. I do that, like, one, grad school, you're here. We all know you're here. Everybody on the planet knows you're here because you're passionate about this stuff. 2, we have to have some formal way of like assessing your progress, right? And grades are just the naturally the most or the easiest way to do so. These grades are arbitrary, folks. When they're not arbitrary, according to your degree, you got to pass, right? But they're arbitrary in relation to your competence. I can promise you that. I know some terrible counselors out there who, as far as we're aware, made perfect scores on their NCE. And they're terrible counselors. So you can know all the knowledge on the planet and not be a good counselor. You can also be a terrible test taker and an absolute super competent counselor. So don't ever get too wrapped up in the grades. Get wrapped up enough to pass, right? To make what you need to make, but get more wrapped up in your own learning. The grades will take care of themselves, and I promise you, I have been known, and I don't really want to announce this, but I will. at the end of the semester, whenever there's a score between like a 91 and a 92, 91 is a B, 92 is an A, right? I will go back and look at those students with 91s, and I'll track and see how much effort they put in this class, because Moodle lets me do that. Every time you even think about Moodle, it logs it in there, by the way. Not really. Hopefully that's not really the case. It'd be scary. But I can track your effort level. And if I see that you put some pretty good effort into this, I've got no problem and will bump you up to an A. Does that make sense? Good. All right. Well, I think we've got everybody that's going to be here. So let me kind of give you the rundown for the game plan is I would like to briefly talk about neurotransmitter systems in relation to normal versus abnormal behaviors. Can be a little bit different what I talked about in the last class, if you were in my last class. And then talk about, primarily tonight, talk about adult ADHD. Not that I'm trying to skip over autism or things like that, but we will cover that stuff in detail in the child and adolescent class, where for this class, I want to highlight something that's really been a phenomenon over the past 3 years that has ramped up substantially. And I can tell you, I am booked out until March. I test 4 to 7 patients a week for neuropsych testing. And about half of those I reserve for ADHD testing of kids and adults. And I am booked out until March right now. Without, except for Christmas, I think, and Thanksgiving, like full weeks. And it just keeps getting added and added and added to it, of people wanting ADHD testing. All right. Well, let's jump into the neurotransmitters. And let's see if I can, yeah, like that. I'm gonna share my screen so that y'all can see this thing. I found this resource online and I thought it was pretty helpful because what it highlights is that our brain is quite complex in the different areas of the brain and what they do functionally. Now, what was funny whenever I started studying neuropsychology is at that time, my mind, I hadn't conceptualized it yet, but I was thinking about the brain as if like you could take the frontal lobe out of somebody, just the frontal lobe, and it would, you know, like if you only had the frontal lobe and nothing else in the brain, in my mind at that time, I was thinking, well, gosh, well, then you would just, you know, you'd have just the executive functions, but you wouldn't have language. You wouldn't have, you know, this person would just, I guess, be able to make good judgment, but not communicate or spatially like process. That's not how the brain works. You can't just take, you know, you can't take a part out and think about it like, okay, well, this part does this, because each part is dependent upon the other parts as a whole for the most part to produce its function. In the same way that like a car is not going to drive if you take the engine out. It's still a car, right? But if you take the engine out, it's not going to work. Or take the brakes out, it'll drive, but it's not going to stop. That's kind of how the brain is put together there. And as I mentioned in the previous class, there's a top down and a bottom up processing. And what you need to really know and hone in on for the purposes of this class, let me get Let me get that pulled up real quick. Let's do. So you really need to get to know these neurotransmitters.
Can you make that bigger?
Can I make this one bigger?
Uh-huh. It's like this size.
Maybe.
It's
Let's
a
see.
postage stamp. There we go.
That's good. Yeah.
Is that better?
Better.
There. So you really need to get to know these neurotransmitters because the vast majority of psychiatric illness comes from disruption to these neurotransmitters. Now, as far as we know now, I'm not saying where we're going to be tomorrow or 5 years or 10 years from now, but most of psychiatric illness is going to be caused by the pathways or connections that are in the brain that are primarily dopaminergic or dopamine based, norepinephrine, which always goes with dopamine, by the way, serotonin, GABA, and glutamate. And actually, we're boiling it down now to glutamate being probably the future of psychiatry, glutamate and its receptors and its complex interaction with all the rest of them as being the primary target for intervention for psychiatric medicine. Y'all have probably heard of ketamine as a form of treatment for resistant treatment depression. Ketamine is a NMDA blocker, basically, which is the glutamate system. If you have too much ketamine, cause you to be dissociated, which is why people abuse it, calling it special K on the street. But at lower doses, it actually is very serotonergic, noradrenergic, and dopaminergic. Even though we're working primarily in the glutamate system. I always think about it like river canals, right? So if you have like this main river, going downstream, and all these little tributaries that come into it. That's what a tributary does. I don't even know if that's right. But glutamate itself is all of, well, let me put it this way. Glutamate itself is the big stream. And what we've been doing with medication, which is also kind of why all that SSRI stuff popped up about depression recently, is we've been targeting all of this indirectly, and not because it's not helpful, because it is. Like if you have not enough dopamine, we know that like essentially you're going to be depressed. But we also know that certain parts of the brain, glutamate as the mainstream, is what regulates how much dopamine is downstream. Is that making sense? And so instead of us targeting dopamine, we might be able to target glutamate and therefore enhance more consistently and with, I would say, more potency downstream effects. It might be able to turn serotonin up over here in this part of the brain and it down over here in this part of the brain. You're going to read about this stuff, and I hope you know that I am oversimplifying what is actually a very complicated process between not just how much of this stuff do we have, but all of the different subtypes and types of receptors for these systems. Because actually, that's where the medications, most of them actually work. And that might be on the presynaptic side or the postsynaptic side or the autoreceptors. And it gets really complicated beyond the scope of this class. But if you learn as much as you can about these neurotransmitters, you'll learn that these have historically and classically done a pretty good job at predicting psychiatric illness when we have either too much or too little in general of one or the other. Okay. I'll give you an example just so you can kind of put your teeth on it. If you have too much dopamine, well, let's say this. Has anybody ever drank too much coffee? If you drink too much coffee, you might feel what? Tired or amped up.
Amped up.
Yep. Maybe even anxious. And probably can't sleep, right? Well, if you can't sleep because you have too much dopamine in your brain, it also probably means that in order to fall asleep, that means our brain has to decrease dopamine. There must be some sort of cycle then, because if we wake up in the morning naturally, and then our bodies naturally want to go to sleep at night, that must mean that there's a variability to dopamine. So if we have too much dopamine, and we don't sleep for a long enough period of time, I don't know if you've ever not slept for like extended periods of time, but you will start having hallucinations. That's normal for extended periods of insomnia. You will also have some paranoia start happening. By the way, anxiety by itself, just feeling anxious, when you have anxiety and you have interpersonal interactions, anxiety is or paranoia is just projected anxiety. So people who are anxious, if they're not around other people, for the most part, if they're not thinking about other people either, they won't be paranoid. But if they're around people and they're anxious, they'll begin to feel increasingly more paranoid the higher their anxiety goes. That's all that paranoia is. It's not a separate process from anxiety. Okay. If you don't have enough dopamine, I'll give you a real clear example of that. If anybody knows what Parkinson's disease is, and Parkinson's is much more than just the tremors. It's much more psychiatric than it is physical, in my opinion. But Parkinson's results in decreased attention span, decreased processing speed, how fast your brain processes and tells your body to move or think, as well as a feeling of flattening, like anhedonia. Anhedonia meaning without, hedonia meaning pleasure, without pleasure, the inability to feel pleasure.
Hmm.
That sounds like a symptom of what?
Depression.
Yeah. Well, guess what? If you increase dopamine with somebody who is depressed, the direct result of that, and I promise you, it will 100% of the time be the direct result, is that they will no longer feel anhedonic.
Can Can you relate that to PSP at all?
Or PSP,
Uh-huh.
like angel dust.
No, and progressive supranuclear palsy.
Oh, okay. PCP is angel dust. Never mind. My brain was on. Why my brain? What was that? I said my brain was on drugs. My brain's not on drugs, guys.
We hope.
I guess my thoughts were still in the drug category. Yeah, PSP, progressive supranuclear palsy,
Mhm.
as a dementia. As a Parkinson's plus
Mhm.
syndrome,
Yes.
including cortical basal degeneration being another one, multiple system atrophy being another subtype of that, Lewy body, or really, I mean, truly Lewy body is another subcategory, but it's kind of overlap too. With all that being said, PSP being the subtypes there for the Parkinsonian syndromes,
Yes.
they stem from where does the pathophysiology occur in the brain more than other places. So in other words, true pure Parkinson's is going to affect primarily the basal ganglia, the substantia nigra. Whereas with like PSP, we're going to have some more brainstem involvement. It's the same pathophysiology, same disease, but it's just going to be located more than other places in the brainstem and through the cranial nerve system and even the cerebellar like projections.
Okay.
Does that make sense? So it's kind of localizing where is the Parkinson's occurring.
Okay.
Mm-hmm. And the reason why we see with PSP, at least initially, a lot of times you don't get the same affective flattening is because you don't have it situated right next to the limbic lobe.
Oh, okay.
I'm not saying they don't have it, because almost all of those syndromes end up looking alike.
Right.
But it may not present initially in the same way.
Right.
Yep.
Okay.
Does that help everybody kind of see how these classical theories have helped us identify, like, okay, well, if they don't have enough serotonin, they're going to be anxious and not sleepy. They're going to be losing weight. Because if we enhance serotonin, it makes them sleepy, makes them less anxious, makes them gain weight. That's why the SSRIs historically cause what? Weight gain. Yep. If you have too much GABA, you are asleep. Think about it this way, roofie, or the rohypnol, is a GABA agonist that ultimately like makes your brain not lay down new memories, and at a high enough dose will make you like unconscious. That's a date rape drug, right?
Mm-hmm.
And if we don't have enough GABA, we are going to be what? GABA makes us sleepy.
Then you're going to be the opposite.
Exactly. Yep. It helps to think about psychiatric illness, by the way, as foundationally being either excitatory or inhibitory as the problem, meaning our bodies are constantly either trying to fall asleep or be awake. If you're too awake, you're anxious. If you're too asleep, you're depressed. Does that make sense?
Mhm.
So that as it relates to psychiatric illness, like depression would be the subjective the subjective experience that too much of your body is fighting for the sleepy side and not for the awake enough side. Now we all know it's a lot more complicated than that because depression always goes with anxiety. So it's not that clear cut, but that's a decent way of conceptualizing some of this stuff. Okay. Let's talk about ADHD and the adult brain. I'm going to share this PowerPoint slide with you. There we go. ADHD in adults, according to DSM-5, what's the cutoff to make this diagnosis age-wise? Like, how old do you have to be? Or like, what's the oldest you could be and still be? Actually, that's a bad question. Let me reword it.
Yeah.
What's the oldest you could be when your symptoms first began in order to still be diagnosed with ADHD? In other words, could you be 50 and your symptoms just now present?
No.
No.
Before 12,
How'd they come up with that?
maybe more complicated school. I don't know.
Well, how'd they come up with age 12?
Arbitrary.
Yeah, they just guessed.
Oh.
Yep. They're like, hey, what do y'all think? Y'all think 11 or 12? Raise your hand if you think 11. Okay. How about 12? All right, let's go with 12. Because it used to be 6. What that means, though, well, let me ask you this. Why do they care? What does it matter to them? If all these neurodevelopmental disorders are supposed to be like diagnosable, so to speak, or I'm sorry, they must be present during the neurodevelopmental time frame, which means that, between conception and 25 or so forth, that the symptoms have to emerge. Why in the world would they just pick 12 for ADHD?
Well, it's in the middle.
It is. And we also know adolescence is kind of round about that time. And I'm a little bit of a cynic, and I don't really have a whole lot of evidence to support this, but I'm also here to tell you is that they're more limiting with the ADHD diagnosis than they are the other ones because of the socio-political cultural climate and stigma tied to the medications that are used for ADHD. So in other words, they're a lot more lenient when it comes to intellectual disorder diagnosis because that doesn't lead to being prescribed an amphetamine. But that's kind of ridiculous, though. I'm not saying that we need to increase the number of people prescribed amphetamine, but what I'm telling you is that a diagnosis of whether or not somebody has it shouldn't depend on whether or not we want a specific outcome or not. We want to control the percentage of people needing treatment. But that's what it's doing. Is everybody following? Okay. So what is ADHD? according to the DSM-5, TR, textual vision, what do you have to have in order to be diagnosed with ADHD? Or your symptoms?
Inattentiveness, hyperactivity, or impulsivity.
Yep. And then as defined by what? Like how, like,
Dysfunction at home, work, school.
So those two things together, then it has to have happened, or at least you
Over
had to have
6
had
months.
symptoms show up
Or at
before
least
age
6
12,
months.
right? Yep.
Uh-huh.
And then for at least 6 months.
So my question is, I have several friends that I jokingly say squirrel to them when they go off on these, they're saying one thing and then they go off on something else. And they always say, oh, it's my ADHD. If they were not diagnosed before they were an adult, they cannot be diagnosed ADHD now.
No, so they can be diagnosed now. It's just that the symptoms of ADHD had to have been present back in their childhood.
Okay. So how do you resolve it if it wasn't? It comes up after menopause or something.
Good question. So at that point, we start to see the limitations of this label, because the truth is, and I'm here to tell you, I would classify myself as such. My symptoms for ADHD didn't really truly cause dysfunction, at least to a noticeable level, until grad school. At which point my ability to compensate had reached its max, and the demands of the world in which I was living outweighed how much I could cope with it. So that is where my symptoms started to emerge. And I'm telling you too, becoming a parent has magnified my ADHD symptoms. There's actually research too, by the way, that we literally becoming a parent causes a decline in cognitive function. And that's the truth. I mean, it's not and it's funny, but it's the truth. But
I used to joke that it went out with my breast milk.
yeah, my wife would say the same thing. But the truth is, a lot of times these symptoms, you can't track them during childhood because of, what if the kid had super duper external frontal lobe parent who did everything for him so that they never had any of these symptoms emerge until that parent wasn't around anymore.
That's
Or
interesting.
either they have it or they don't. But
Could it also be that they just didn't have access to testing and resources, and
yes,
I mean, that really wasn't a thing when I was younger.
Right. It wasn't a thing for me either, really, unless you were getting arrested.
Right.
And that's the fact is that we can't say that there's no such thing. There is an adult onset ADHD, but what that means is that it's just now showing up symptom wise but it's always been there. It's just now showing up for whatever reason. It might be a medical reason, it might be a social reason or a stress reason, but it's possible that it's been mitigated this whole time and we're just now seeing it in adulthood. But when we define what ADHD is, it has to be there during the neurodevelopmental period though, but we won't always be able to pinpoint that it was. Because when you ask a patient who's 40 to say, well, tell me about kindergarten. Well, I'll tell you, Miss Russell was the teacher name. And I remember my friend Michael, we were friends for most of that year until the only thing I remember is him picking his nose and eating his boogers, and then we weren't friends. That's all I remember. And if you don't have a parent that you can contact, or if we can't get in touch with Miss Russell, and who knows if she remembers who I am. But that's what psychiatry really wants to force on diagnostics with ADHD right now. They're trying to really make sure that every psychiatrist is telling their patient, hey, I want you to go track down all of your report cards. I want you to get all your academic records, and I'm going to need, a spouse report or a partner report or employer report and all this kinds of stuff. And I
So
get
really,
it
it has to
because
be external to the client. It can't be like just self-reported. It's got to be external sources that are collaborating that.
that's what psychiatry would prefer. What I would say is that it's a case-by-case basis, and if we can't base a diagnosis off of self-report, the only other way that we could do this is if we had like a brain imaging modality to separate ADHD from non, which we don't, by the way. I don't care what Daniel Amen says. We do not have that ability. Or some sort of testing of brain functions that would be specific enough with a history to make that diagnosis, which I'm obviously biased for because that's what I do professionally. I spend half my time in practice testing for ADHD. And I can tell you, there's a relatively specific pattern of scores that I get when I do a full battery of the whole brain. And it helps to have as much context and medical context and ruling out everything else. Combining all that together, in my opinion, is the best way to make this diagnosis.
What's it seems like it's becoming much more common, I don't know if it's becoming more common or just people are testing more for it, or it just seems like what's the percentages of people that adults, children, whatever, that have ADHD or that are being diagnosed with it now?
The prevalence rates have ranged from, I think it's like 5% to 20% of the population. We don't really have, so what's hard is that, again, we're trying to, anytime we take a prevalence rate of any of this stuff, that prevalence rate is only as good as the underlying diagnostic criteria or specificity of that criteria. And when you read about it, you'll see that the truth is, they'll say, well, in order to do this prevalence rate study, we weeded out or ruled out, the presence of autism or OCD. And I always think to myself, how in the world did they do that? I can't do that. And I've got every test available to me under the sun, and all I did was a 30-minute interview. And you're telling me that interviewer for that study was better than me after years and years and years of doing this stuff, being able to rule out and split the hair between OCD and ADHD and autism? No way. Now, do I do that? Yes. I have made the diagnosis of OCD by itself. I've made the diagnosis of autism by itself and ADHD by itself. But I know that they didn't do what I did, and I have a hard time doing those things.
Can I ask you one more thing?
Sure.
I'm curious about this, the whole, I don't know what we call it, the topic or description of neurodivergent and neurodiversity and that whole sort of movement. Is that just another way of talking about all of these things, or is this I don't know, I want your view on that.
So neurodiversity being a cultural sensitivity of the range of what really and truly it's even within the ADHD community itself, there's multiple cultures, subcultures, and including autism too, by the way, where some folks are saying, hey, this is a disability, it's a neurological disability. Others are saying this shouldn't even be a label. In fact, I'm better than everybody else because I have it. So there's a wide range there. Ultimately, my question with patients is always, how do you approach labels? What meaning do you find in these labels? And if I suspect that you have or meet the criteria for one of these labels, what impact might that have on you? So those are always good conversations, because it's going to be, in my opinion, all that stuff is going to be defined by the individual. But that's mainly because I'm a postmodernist.
Thanks.
Yep. I'm gonna take just a couple minute break here because I need to use the restroom real quick, but we will get going in just, I would say, in 5 minutes max. Okay.
You guys have these slides that he's using tonight. I can't find them in Moodle. It's probably week 3 slides, but I don't see them.
I saw some of them in week 2.
Okay, that's where they're at.
I can't tell you if all of them, but I did notice some of them. Do you see them?
Not the exact ones he has up there. Some of the ones with like the diagnostic criteria are there, but
Mm-hmm.
the colorful ones I don't see.
Oh,
Maybe maybe we don't need those. Maybe they're just for, or we can watch this video.
or maybe he'll post them later. Wow.
Take a picture of it.
No idea. Dan, I have no idea.
Yeah, I'm just really curious about that.
Yeah, I couldn't tell you. I'll have to do some research on that one.
Are you in the LPC program or LMFT?
LPC. Whatever that's called.
Yeah. How far are you along?
I just started.
You just started.
Yeah, it's this summer was my first.
Okay. What do you plan to do with it?
I don't, I mean, go into private, would really like to work with grief.
Mm. That's a big one.
Yeah,
I mean, who doesn't run into grief multiple times during their life, you know?
right.
Yeah. Hmm.
Not only with physical, not only with death, right? Grief comes up in lots of different ways.
Right. This is true.
There's some organizations in town, you may have heard of them. One's called Grief Works and one's called Journeys of Hope. You might find it interesting to, I don't know, volunteer or something if they need, be connected with those organizations. Just, they work with families after loss.
Right.
And it's pretty neat. It's a group system. So they'll have like, you know, a group for the parent, like maybe like the sibling of, let's say a child died, maybe a siblings group, a parent group, it's spouse group, different groups around the loss.
But are those both in Dallas?
Oh, are you not? Where are you?
I'm in Fort Worth.
I think GriefWorks could have other offices. It's a larger organization. Journeys of Hope, I believe, is in Dallas or Plano,
Okay.
even maybe.
Okay.
But I'm sure they have something similar.
Okay.
Maybe his kids got a hold of him.
We're going to restrict his liquid intake from now on.
All right, y'all still there?
Yeah.
All right.
Hi.
Somebody had a question, is our sensory sensitivities processing problems part of any psychological disorder, or is that its own thing? The sensory processing disorder is not a diagnosis that is in our DSM-5 or ICD-10. which means it's not recognized as a real thing. And I'm here to tell you that I've seen a lot of kiddos and adults for that matter, who either or who were labeled as having sensory processing disorder and told that that's what what it was, when in reality, that was just a small piece of what should have been more accurately labeled as either autism, ADHD, or OCD, or all of the above. I'm not saying that sensory processing problems don't occur, they do. But I've never seen them occur outside of the diagnosis of at least one of those three.
Got it. Thanks.
Is this slideshow that you're showing us right now on, I can't find it on Moodle. Is it something that you'll post on Moodle?
It should be on Moodle.
It's there. I saw it.
I don't see it. Okay, I'll look further. Is it week 3?
It is week 3, I think.
Yeah, okay. I just have to, I'll find it.
Yeah, it's week 3. Somewhere. A week. Where's it at? Because I downloaded it from our good grief. Maybe I only had it in the other class, so let me fix that.
Okay, thank you.
I'll probably put it in there twice now because I can't find it, but you're nothing wrong with you. I can't find it either. So I'll put it in week 3 though.
Thank you.
I'll do that right now before I forget. All right, so with adults onset ADHD, we're going to recognize that it was not probably, it has to have been there all along. It's just that if we're just now seeing the symptoms, it's possible that that person just coped with it up until this point. So a lot of times major life transitions is when people start seeing the symptoms emerge, and that doesn't mean that they weren't always there. It just means that this transition might have pushed them beyond what they could cope. Then the question is, well, how do we know it's not depression? Or how do we know it's not just transient anxiety or stress or lack of sleep or sleep disorder or a million other things? Well, I'm glad you're asking those questions, because those are questions that you need to ask yourself. And which is why this is not an easy diagnosis to make. And at the end of it all, it ends up being our best guess based on as many puzzle pieces that we can put together. Which also implies that the fewer puzzle pieces we have, the less accurate our diagnosis is going to be. Does that make sense? So you can't just do like a history. Because I'm telling you right now, especially in the past year, almost all of my adults coming in with that suspect they have ADHD, they've already researched this thing and have convinced themselves that they have ADHD and are looking for me to just tell them that they're right. But sometimes they're not right, which makes it a little bit difficult, but it's going to
So do they
hinge
have
on
something else? They have something else, or they don't really have anything and they're just like attributing it, whatever they're struggling with, to ADHD?
Sometimes I mean, it's pretty rare, but I have had a few people that I would qualify it as an adjustment disorder, because if it's affected them enough for them to come see me, like, to me, that I've never had a patient come in and is like, man, my life's great. I just kind of want to know if I've got it. And that's never happened. And so if they're coming to see me, usually something is affecting them enough to at least meet the criteria for like adjustment disorder. But it'll range from being, a lot of those folks are correct that they have it, but it ranges from being correct to, I didn't even know that I had a B12 deficiency, iron deficiency. Or if I ask them, when's the last time you had your thyroid checked? What's a thyroid? Had my oil changed a couple weeks ago. I literally had an old man from Paris, Texas, that is, tell me that one time. I said, when's the last time you had your thyroid checked? Well, I don't know. I had my oil changed like 2 weeks ago. Well, is your alternator okay? Yeah. But and I've had patients who have sleep disorders, a lot of patients with sleep disorders. But here's the thing, can you have hypothyroidism, pernicious anemia, which is what that B12 deficiency would result in, or obstructive sleep apnea and ADHD? They're not mutually exclusive. But all those things that I just listed off could also just be mimicking what appears to be ADHD symptoms. Welcome to the complexity of trying to make a diagnosis. And that's just ADHD, because there's other stuff that can mimic it too, like anxiety disorders and depression. I've never met a depressed patient who reported normal attention abilities or normal executive functions for that matter. So in my opinion, and I'm a little bit biased, but we have to do the best we can with gathering as much information as we can about this patient's early childhood history, academic history, social history, all of that, because that time period is when this thing had to have begun. And just because we don't highlight the detail there doesn't mean that we have all the puzzle pieces. But if we don't have it there, then we look at, okay, well, how is this person, when did these symptoms first emerge? What was the context? What's the history? What did they do to help them go away? What didn't work? But I'm here to tell you, I can promise you, almost every adult with ADHD has either like this OCD, like perfectionistic kind of drive, and it looks like generalized anxiety disorder predominantly. But it's like this overcompensating perfectionism. They're just very high strung. When I say high strung, but just wound tight. Anticipating failure all the time, just really revved up. Or we've got the adult with ADHD that is of overt underachiever. So like they're brilliant, but they're vocationally or relationally or whatever doesn't match their potential. Those are the two, and I'm just giving you the two anecdotal kind of stereotypes that I see frequently in practice. And this type, the driven perfectionistic type, is a lot more difficult to pick out than the other type, because this type looks looks more like it might be just that we need to focus on it, but it's more the anxiety that's prominent. And these are the folks that are usually the ones who have trouble sleeping at night, can't turn their mind off, will have OCD-like qualities to them, but are probably best labeled under the ADHD predominantly inattentive presentation. Because it's their anxiety is what the symptom is. And if you think about it, the inability to regulate or inhibit one's thoughts or impulsive thoughts is just as impulsive as the inability to regulate an impulsive behavior. Okay. I am going to have to wrap this up right there. I'm sorry to just land right there for tonight, but we'll give you just a couple minutes for questions, like 2 or 3 minutes here, and then but we will plan on for next week, and this was all recorded, so I will upload it. What questions do y'all have for me?
I have one that's not concerning ADHD.
Okay, yeah.
When I was doing my reading, I noticed that they put Down syndrome and Alzheimer's together a lot.
Mm-hmm.
And I was wondering, how much do you think a lot of these syndromes and problems are genetic? Like Parkinson's, like.
I would say this is that we're talking about two things when we talk about what causes these conditions. So like for any individual, what I'm about to say doesn't really apply because we're talking about averages.
Mm-hmm.
But for the average person with ADHD, for the average person with Alzheimer's or Parkinson's or whatever the diagnosis is, there tends to be a predisposition, genetic predisposition factor, and then an environmental factor or factors that combine to result in the diagnosis.
Perfect storm.
But for any individual, that may or may not, it might vary with more genetic predisposition and less environmental input versus no genetic predisposition and a whole lot of environmental input. Because I promise you that there are pesticides out there that you can have no Parkinsonian predisposition, but if you're exposed to enough to that pesticide, or like, let's say welders, like there's manganese, if you get enough manganese in your brain, you will develop Parkinson's.
Okay.
And that's with or without having any genetic predisposition. So on average, we've got a range between 40 and 60% being genetic and 40 and 60% being environment.
Okay.
With ADHD, it's closer to about 60 to 70% genetic on average.
Okay.
Mm-hmm.
Okay. Thank you.
Mm-hmm. Absolutely. Well, thanks, folks. Thanks for hanging in there on a Sunday night. And hope you all have a wonderful week and that it stays nice and cool out there. And we'll plan on next Sunday.
Thank you so much.
For sure. We'll see y'all next week.
Thanks.
All right. Take care.